are the chairs of the model working group who worked on this very challenging guideline, which is really critical for clinical practice, and that will discuss the management of basilar artery occlusion, patients with ischemic stroke, and we will hear firsthand the new recommendations, and there will be a simultaneous publication of the author accepted manuscript in the European Stroke Journal. So we very much look forward to hearing you. Thank you.
Thank you, Diana. Thank you, Terry. So in the few minutes, we will make our best with Wim to present you the outcome of what we have been doing for many months. But before I start, I would like to thank a lot to Editor-in-Chief of the European Stroke Journal, Kennedy Lees, without whom it would not be possible to have the simultaneous publication today. So I would like to thank you, Ken, a lot. We had comments from 9 reviewers altogether, so it was quite a work to answer in a due time. So this, as you know, so this is absolutely impossible to prepare such a guideline without a huge group. So in our group, we had altogether 13 members. 10 have been voting and 3 non-voting fellow members. The distribution was roughly 7 representatives from ESMINT and 6 from ESO. And about the voting members, 5 and 5. I believe we had quite nice gender balance in the group. So Wim was the co-chair from the ESMINT and I was from ESO. All declaration and conflict of interest can be found in the full publication. And before we go to the PICO questions, so there are altogether 10. I am going to present 5 and Wim 5. And as there is mentioned, so all the grade methodology is actually based on very comprehensive and systematic approach of the grade, which comes, of course, with a package because the way we evaluate the evidence has many steps before the final recommendation can be postulated. And that was the cornerstone of the guidelines for ESO for many years, the grade methodology. So this is as well what is our guideline based on. So in first of the 10 PICO questions was, I believe, quite obvious. Although you can imagine that we don't have any randomized data for this question, we believed in the group that it's very important to answer, do we have any evidence for basilar artery occlusion patients that presented within 24 hours after last seen well, if intravenous thrombolysis is better than no IVT? So it's no surprise that no randomized data were found to answer this PICO question. And if this is the case, we needed to have some supporting information and then formulate an expert consensus statement. We don't have time to go through all of the supporting information, so please, if you, actually I think it's very important that you maybe must see all of the supporting information in the printed publication because there are a lot of data. And we can just show maybe a very small proportion of it in this guideline session. So because we didn't find any evidence-based recommendation for this PICO question, we found for some supporting evidence to guide our expert consensus statement. So first of all, we consulted what we already know from the previously published guideline on IVT thrombolysis, written by Guillaume Turc and the colleagues. Then we as well used data from the BASICS registry, not trial, and then some data from the non-randomized studies. Some of those come actually from Helsinki, and in one of those studies that included patients up to actually even beyond 24 hours from last seen well. Roughly every second patient was treated within 6-hour time window and every second beyond. The modified ranking scale outcome 0 to 3 was 47% in patients treated with IVT only, with median NIH 18, and the risk of, or the proportion of the symptomatic hemorrhage was actually very much comparable to those seen in randomized trial in the EVT group. So based on the discussion in the group, based on the supporting information that you can find in the full publication, we divided the expert consensus statement into 3 parts based on the time window. Within 4.5 hours, 4.5 to 12, and 12 to 24. So for the first part of the expert consensus, all 10 members suggested that in case there is no extensive bilateral or brainstem changes, all of us supported to give thrombolysis to patients with basilar artery occlusion. Then for both other time windows, 4.5 to 12 and 12 to 24 hours, the recommendation was the same, but in this case, it was not done by 10 of the 10 members, but as you can see, 8 of 10 members suggested intravenous thrombolysis up to 24 hours, but I need to stress out it's for the patients who do not have extensive ischemic changes in the posterior fossa apparent presentation. While coming to the PICO 2, I will hand over to Wim.
Yes, thank you, Daniel. And I'm honored to be part of this group, but I must say that most credits should go to Daniel. He spent half of his life on this guideline, I think, and you see most of his gray hairs, I think, come from this guideline. But you know that the reason to write this guideline is mainly driven by the trials that investigated endovascular treatment of basilar artery occlusions, and they have been published recently, and we will go through them in two sets because we split it up in early window up to 6 hours and the late window beyond 6 hours. This is finally what we recommend or what we suggest, because what you also see is that the quality of evidence is very low. And I talked with many people that say, how can you say with these nice and well done trials, the evidence is very low? I will show you. We follow the great systematics. And what you will see that if you look to the quality of evidence of those trials, that there are some flaws. And if there are some flaws, you cannot say that the evidence is very, very strong. So this is the reason that we still keep it on the very low quality of evidence. But all trials that we used, the randomized control trial, pointed in the same direction, that there is a benefit of endovascular treatment between 0 and 6 hours. For basilar artery occlusions. So what we also saw, if we split it up in the two trials, the two main trials that contributed to this data, the BASICS trial had a high percentage of IV-treated patients. So in the control group also there is a high percentage, up to 80%, that is IV-treated, IV lytics. In the attention trial, the trial from China, that was a very low percentage. That might be a reason, that might be something to consider in line with what you said about IV treatment for basilar artery occlusions. So the evidence for the primary outcome in what we thought is the main driver was the MRS 0 to 3, was very positive, but you see the same effect in MRS 0 to 2. There's a positive effect if you combine those three trials. And the same, of course, there is a difference in the high and low percentages of IV treatment in those two trials. So that was the main thing for up to 6 hours. Now, some trials included patients beyond 6 hours. Attention included quite some patients beyond 6 hours, and Baorche was even a trial that included only patients beyond 6 hours, 6 to 24 hours. So we have more or less the same recommendation. One thing that you read also in the previous one is that the recommendation considers only patients with an NASS of more than 10, and I will come to that because that was the next PICO 4, but I'll come to that later. Here you see the evidence, again, is very low, and with the same rationale that if there's a flaw in this evidence table, then we should consider it very low. But still, the effect is pointing in the same direction. There is an effect also in the late window for endovascular treatment in basilar artery occlusions. So that brings me to this PICO 4. We wondered whether there is a modification of the treatment effect by either the location or, in this case, the severity of the symptoms. And we know from the BASICS trial that did a analysis, a predefined analysis on subgroups of beyond 10 and below 10 NISSS, and they saw that the effect, although it was not a positive trial, it was neutral effect, the overall group, but the NISSS above 10 seemed to be very positive, while below 10 was even at the other side. There could even be harm. Anyway, we looked at the data that is available, whether we could find this difference, and we also looked at the data if we could find a difference in effect on the location of the clot in the basilar artery. Now, the first thing that we saw, that the effect was very strong in the NISS above 10. So we suggest endovascular treatment definitely in this group. You also see in smaller letters that the effect is stronger for proximal and middle location. Now, I'll show you the data in a minute. We also suggest best medical treatment in the group below 10. So below 10, which was in line with the group in the BASICS trial, we cannot recommend to do endovascular treatment. And you may say that in, for example, Baorche, they included patients from 6 upwards, but there were very, very few patients with an NIHSS below 10. So we cannot draw any conclusion from that. So we have these data now, mainly from the BASICS trial, that below 10 there seems to be no benefit. So we suggest that you use best medical treatment over endovascular. So we do not suggest endovascular treatment in this subgroup. Another thing that we also wrote is that these data come from a randomized trial with low prevalence of ICAT in the Dutch trial. In the Chinese trial, as you know, the Baorche and the Attention trial, there is a much higher percentage of intracranial atherosclerotic disease. That might, well, you might take that in consideration as well. Okay, so here you see what I wanted to say, that below 10, we see it in the BASICS trial, but in the Baorche trial, the numbers are so small that we can't add that up to the evidence. So we cannot recommend endovascular treatment in this group, but above 10, there is definitely a positive treatment effect in all those trials. For the location, there is a significant interaction that you can see in the bottom line, and the effect is definitely higher in the proximal occlusions, much higher than in the distal, but still there is a very, very small effect in the distal occlusions as well. So it's not that we will recommend not to do endovascular treatment in distal occlusions, but there is a treatment modification effect by the location. Okay, that is about the endovascular treatment, early window, late window, and the differences, the effect modification by those different factors. I hand over again to Daniel.
Thank you, Wim. So in another PICO question, we ask, what is the role of the early ischemic changes, in this case represented by findings in the PC aspects score? So shall we guide our decision based on those scores of the PC aspects? So for PC aspects 7 to 10, it's very easy, because our suggestion is just to follow all other recommendations. So pretty much we recommend everything, but we recommend in all other PICO questions is valid for those patients. So the most important part of this PICO question was, of course, the patients with low PC aspects of 0 to 6, for which, again, we could not find any randomized data, and we needed to do an expert consensus statement. This consists of 2 parts. Our suggestion in expert consensus statement, 10 out of 10 members suggested that if you have a patient with low PC aspect score, which means lower than in those patients that have been included into randomized control trials, PC aspect 0 to 6, consider all other possible parameters like age, frailty, and pre-stroke handicap before you offer a reperfusion therapy. And 7 of 10 group members suggested against reperfusion therapy in case you have a patient who has already on baseline very extensive bilateral and brainstem lesions. So this is the suggestion of expert consensus for PICO 5. In PICO 6, we ask about another, let's call it advanced imaging, collateral score, and so on, if we can judge our treatment decision based on collateral scores or perfusion or some other advanced imaging. Again, unfortunately, we do not have any randomized data to guide our decision. That is why we ended up with an expert consensus statement, and all members suggest that we consider, in case if patient does not have extensive ischemic changes in the baseline, that we should give the treatment, reperfusion treatment, irrespective of any collateral score. For example, like Batman or something similar. In PICO 7, we ask the question, if we have a patient with basilar artery occlusion, and the IVT is not contraindicated. Is direct endovascular thrombectomy better compared to endovascular thrombectomy plus IVT, or actually it's IVT plus EVT? So in this case, with low quality of evidence, we suggest combined IVT plus EVT approach over direct EVT. Some of the supporting information comes from non-randomized data. So as we can see, we have the adjusted and unadjusted trials, altogether 5, that all point to the same direction, and they favor IVT plus EVT. This is for modified Rankin scale 0 to 2. And then the same was found for the shift modified Rankin scale at 3 months. And if we think about the risk of symptomatic intracranial hemorrhage, it was the same in both groups. With this one, I hand over to Wim.
Yes, then another question that always comes up if you're an interventionalist, if you do such a treatment, should you go for a stent retriever procedure or should you do aspiration first? As you know, in the anterior circulation occlusions, there have been many trials addressing this point, and there's not real, let's say, evidence that one is better than the other. So we looked at the evidence for basilar artery occlusions, if we could find some evidence. And there is some evidence that shows that aspiration in this particular group, the basilar artery occlusions, works better as first-line strategy than a stent retriever. So we suggest using direct aspiration over stent retriever as first-line strategy. And that comes from these trials. It's a very heterogeneous group of studies, but finally I think we have enough points to say, okay, aspiration in this particular location probably works better than stent retriever as a first attempt. So that is finally the recommendation. Also the technical outcome, so the reperfusion grade 2B to 3 was higher in the aspiration group than in the stent retriever group in all those studies. The next question that we asked ourselves, there is a higher percentage of intracranial atherosclerotic disease in the basilar artery than in the anterior circulation, also in the non-Asian population. In the Asian population, it's in both territories much higher than in the Caucasian population, but also in our population, the Western population, we see a higher grade of ICATS, intracranial atherosclerotic disease, in the basilar artery. But still, we do not have evidence what is the best treatment option there. Should we do PTA, angioplasty, or should we place a stent? So then there is, of course, this expert consensus statement, and all the experts agreed that in that case, if you have residual stenosis or occlusion, that PTA and or stenting is recommended. So that is the suggestion that comes from this literature, well, finally from the experts, because we don't have the real evidence from the literature. Then the last PICO is for Daniel again.
Thank you, Wim. So in the last PICO, we asked that if we have a patient, adult with basilar artery occlusion, and the patient is subjected to reperfusion therapy, it could be IVT or EVT. So do we as well give the patient add-on antithrombotic therapy during endovascular procedure or within 24 hours after? And now it's very important to consider that the recommendation that we postulated has very low evidence, and it's only valid for patients who only undergo endovascular procedure without concomitant intravenous thrombolysis, and only in cases when the endovascular procedure is complicated, which means either its procedure is failed or you have imminent reocclusion or a need for additional stenting or angioplasty. So as you can see, extremely complicated situation. For such patients who, again, did not receive IV thrombolysis, which suggest add-on antithrombotics, either during EVT or within 24 hours after. And actually, the statement, if you go to look about the guideline that was published some years ago by Marios Psychogos as the first author, so of course there is some more information in that guideline. And this was our final PICO question, and now I hand over to Wim about some future aspects.
Yeah, we were debating a bit what are still open questions, and we put some questions here on this slide. There are many things that you can you still need to find out. This was only about basilar artery occlusions, and we know that there are also other posterior circulation branches that can be occluded. So this is not about the PCA or the ICA or the PICA or the vertebral arteries. In fact, it's about basilar artery occlusion. So we need more evidence on that. Clinical characteristics, we shown that only in one trial, a trial that was in fact in total neutral, that the below 10 NAHSS seem not to benefit, but we don't have real data on this specific group. So maybe we should need more evidence from these patients as well. Some other topics, I don't want to go over all of them. Cost effectiveness is always an interesting thing. We didn't do that yet in those trials so much, but that's of course of interest, although we know that endovascular treatment is very cost effective in the anterior circulation. Probably IV treatment is just as effective, cost effective as in the anterior circulation, in the posterior circulation. Neuroprotection, I won't go into all those details. I think we go to the conclusion, and a lot of literature that we went through, but very, very real strong evidence, I should say. So if you can read it properly, it all says suggested, and suggested means that the evidence is quite low. So we suggest IV treatment for basilar artery occlusions, but up to 24 hours. We suggest endovascular treatment for basilar artery occlusions, also up to 24 hours, but with a caveat, above 10 we have the evidence, below 10 it seems, well, it could even harm if we look at those few data from the BASICS trial, and we don't have much other data about this subgroup. But that will come, that you told me from the SITS group, so we might have more evidence about this specific low NAHSS group with a basilar artery occlusion quite soon. Reperfusion treatment is suggested again in absence of extensive bilateral brainstem ischemic lesions. All right, aspiration is suggested from these heterogeneous data above stent retrieve as a first attempt. Rescue, PTA or stenting also is suggested, but based on expert opinion. I think that most interventionalists do treat patients with a residual stenosis or occlusion with either PTO, mostly with a stent. And on antithrombotic treatment is suggested in complicated, it's always a difficult term, complicated endovascular treatments, and no concomitant intravenous thrombolytics. I think that summarizes more or less all those 10 PICOs. So thank you for your attention, and I think we can have questions now.
So thank you, Daniel. Thank you, Wim. It's been a huge amount of work, so thank you for presenting it. When we ran the guideline session last year, the feedback was less guidelines, more time for Q&A, so we listened. So we're now going to open the floor for questions. On the desk in front of you is a microphone and a little button. So does anyone have questions for Daniel or Wim?
Marcel.
Congratulations for this excellent work. I have only major concern for this negative recommendation based on a subgroup analysis and dichotomized less than 10. Is this based on the primary outcome 0 to 3, or did you also MRS shifts, or perhaps in this minor to moderate stroke, my primary aim is to have a MRS 1 or 2 and not 3. There might be some methodological danger, but I'm sure you considered this.
Yes, Marcel, of course, as we mentioned several times, this was something that we look at quite a lot. And that's why it's very important that maybe you see the whole publication, because we cannot show all of the supporting material here. So there are, like, altogether when we voted for the outcomes, we have 7 outcomes that we evaluated, including shift analysis, modified ranking scale 0 to 3, 0 to 2, hemorrhages, mortality, and recognition. And this is only just some of the data that Wim was showing. And one of the study that Wim was just talking about, I think I can tell about it because it was presented in conference. It's under consideration in journal. It's the analysis of 2,000 patients from the Karolinska SITS registry that analyzed patients from for the low NIH. Control group was pure 100% IVT. and it was better compared to EVT plus minus IVT in the paper. So, but it's, as I told you, it's under consideration in journal. But in the paper, in our publication, you will find all the 7 outcomes, not only one.
We do have time for more questions if there are.
Here's one.
Fana and Sagad here, beautiful guidelines. Can you comment on the use of tenecteplase in basilar artery occlusion?
Sure.
Well, thank you, Fana. Yes, I was thinking a lot about you and your trial after listening to today's presentations that, a lot of centers are actually shifting based on the data that we have about the tenecteplase to switch from alteplase to tenecteplase. So we don't have the data. You are running the trial, so most probably, I believe that what we are saying about anterior circulation, maybe most centers will be do as well for the posterior circulation. But I have exactly the same data as you have, so I cannot answer maybe more.
Any more? I saw the peer reviews. I know there's a lot of strong opinion on this.
May I maybe add another question, a very practical question for all clinicians seeing patients with stroke in the acute phase. So, for example, you showed us that IVT changes the effect of EVT. So, if you have a patient, imagine NIHSS9, hemiplegia, the patient has a contraindication for IVT, is on AFib, on anticoagulation, and it's still currently a formal contraindication, for example. There is quite some uncertainty around the data on this recommendation still. What is your take on this kind of difficult situation?
Well, first thing you said that IVT seems to have an effect on endovascular treatment. I think the most important part is that IVT has an effect on the control group that does better with IVT, and that makes the treatment benefit smaller in patients on IV treatment. But your question was about patients that are already on antiplatelets or?
That have a contraindication for intravenous thrombolysis and have no other treatment available other than endovascular treatment.
Yeah, so then probably the endovascular treatment recommendation is much stronger, but we have not put this in our guidelines now. But I agree with you that if a large part of the lower treatment effect is due to the IV treatment in the control group, then of course, if you don't have IV treatment on board, then the effect will be much stronger.
And I agree 100%.
Okay, we've probably got time for one more, yes.
Thank you for a fantastic guideline. I'm a little bit wondering about stenting, because you have all these penetrating arteries. Could you comment a little bit more about pros and cons on stenting, please?
I could. It's that is a difficult topic. We do place stents more often in the basilar artery occlusion, also, for example, for aneurysm treatments, and we know that there is a danger that perforators will get occluded. But still, in this case, when a basilar artery occlusion does not open completely, you take the risk to place a stent. I think the biggest risk is the antiplatelet that you have to give. You have to be quite aggressive with antiplatelet therapy in these intracranial vessels when you place a stent. So you increase significantly the risk of hemorrhage, and I think that risk is even higher. But as we've shown, there are not so much data. So we have to depend on expert opinions, as we did. And, well, it seems that most experts place a stent in these situations.
I see we have someone desperate to ask a question here, so we'll squeeze one more in.
Just a comment. There is an observational study on the use of thrombolysis and stenting after thrombectomy, which suggests that there is no additional risk of giving antiplatelets.
No additional risk of giving antiplatelet. Yeah, well, that doesn't really answer your question whether the perforators are in danger when you place a stent. But yeah, that's right. Yeah. So okay, I'm not aware of that, but that means that with this antiplatelet, there's not a higher risk of bleeding, you say?
Okay, I think we will need to wrap up there. I'm sure there's lots of other questions, but you'll have to catch Wim and Daniel after the session. So let's thank our speakers again. And it's now my great pleasure to introduce our second speaker, Professor Valeria Castle. She is Professor in University of Perugia, consultant neurologist, well known to an ESO audience, having held lots of leadership positions in ESO, but she's going to present the guide